ahead and introduce yourself.
So I'm Alok Jain. I'm a psychiatrist, board certified in psychiatry and addiction.
I am Brianna Jain, and I am a doctor in nursing practice, and I am board certified in psychiatry and addiction as well.
You go ahead.
Okay, so our PowerPoint is not, we're gonna veer from this. Is more just a guide, visual aid. We're gonna be covering giving some basic prescribing pearls on several different class of medications. It's not gonna be detailed into the mechanism of action and such behind each class, because that would be each one of those a separate lecture. So basically, we're gonna tell you class by class kind of what you need to know, and the basic things that will make you more familiar with each class of medication, indication, et cetera, so that when you are seeing them in whatever discipline you're going into, hopefully some of these things will stick. We can go to the next slide. So what is a psychotropic? That's pretty easy. It's just something that affects the mind, emotions, behavior. The important thing is no matter what discipline you guys are going into, you're gonna see psychotropic medications. If you're in oncology, nephrology, I mean, mental health, it's going to touch all walks of life, all patients, all ages. And so no matter what discipline you're in, and we've had this conversation with the students that have been at our site, you're gonna see psychotropic medications, and they do affect a lot more than just the brain. So side effects of these medications, as well as certain mechanism of action, can affect the metabolic system, the neuroendocrine, nephrology, hematology, basically, well, not oncology, but most of them. And there's a lot of drug-drug interactions and things that you need to be aware of. I think this is an understatement, but it says 16.5% of adult Americans were on medications for mental health as of 2021. Those were pre-COVID statistics. I don't know what they are now. They don't have that data out yet. But that means a lot of people are taking medications for their mental health. And you're gonna see those popping up when you're reconciling meds and looking at, what your patients are taking. Anything on psychotropic?
Yeah, you just need to know pharmacokinetics and pharmacodynamics. Pharmacokinetics is what the body does to the drug. Pharmacodynamics is what the drug does to the body. Let's start with SSRIs. So selective serotonin reuptake inhibitor.
You guys have a
Yeah, I'm
little-
not gonna go into any of this. I'll just start talking about
Okay, next.
antidepressants. SSRIs, they are selective serotonin reuptake inhibitors. They block the reuptake of serotonin. So before you know what to prescribe, you need to have an accurate diagnosis and differential diagnosis. So if you see a patient who's depressed, you do not automatically just jump and start prescribing an antidepressant. You need to make an accurate diagnosis, figure out what's going on, what are the possible medical etiologies, non-psychiatric etiologies. So Brianna, what are some of the non-psychiatric etiologies that can cause depressive symptoms?
I mean, thyroid dysfunction is a big one, vitamin deficiencies, fatigue, there's any number.
Exactly. You can have like patients who have severe anxiety and they can have thyrotoxicosis going on. So exophthalmos, what is exophthalmos? Bulging of eyes, right? So I've seen patients who had like myxedema, who had like profoundly hypothyroid with TSH of 160, 200, something crazy like that. So you need to rule out all the medical causes. So once you diagnose a patient with major depressive disorder or with dysthymic disorder, which is persistent depressive disorder, then you decide what antidepressant to prescribe. Now, before you start prescribing an antidepressant, you need to make sure that you're excluding bipolar disorder. What will happen to a patient if you put them on a SSRI and the patient has underlying bipolar disorder? Exactly. Okay, now I'm not going to go into diagnostic criteria. It's also important to know what is the number one cause of therapeutic failure in psychotropics as a category. Is it wrong diagnosis? Is it treatment non-adherence? Or exactly, right? Treatment non-adherence. So majority, what percentage of patients are treatment non-adherent in clinical practice?
I mean, statistically or in our clinical practice?
In real life?
I mean, I would say 40 to 50%.
Yeah, but more than that. It's more like, 70 to 80% of patients are treatment
It's very
non-compliant.
common for people to just disappear and then us see them 6 months later and them say, I went off all my meds and now I'm severely depressed. And so we have to do a lot of inquiry. Are you taking your meds and are you taking them as prescribed? I think compliance has improved. The longer I've been in practice, I'm seeing people be more compliant with their meds. But I mean, it's still a big issue. It's more, even more so when we get into the psychotic disorders.
I mean, how many of you take multivitamin? Okay, how many of you remember to take multivitamin every single day of your life? It's so hard to take a multivitamin now. Imagine putting a patient on an antidepressant or any psychotropic where you're prescribing them BID or TID or QID dosing. It's pretty much impossible for them to
And
take that.
unfortunately, our SSRIs do not come in a long-acting form like some of our other medications. So we do look at, so if we were going down just the list of your general SSRIs, some basic prescribing principles. What antidepressant would you want to avoid in a patient with QTC prolongation, for example?
Amitriptyline.
So sorry, which SSRI?
Amitriptyline is correct.
Yes, sorry, but Celexa. So Celexa prolongs QTC when we're talking SSRIs. You need a baseline EKG with that. Top dosing of Celexa is 40. It used to be we go much higher, but then the FDA came back and said, no, Alexapro to a lesser degree, but it's still possible. So you want to be looking at that. A lot of people throw Celexa like it's candy. That's because from a hepatic standpoint, it is relatively safe. It is pretty well tolerated weight neutral medication, but you really need to be inquiring family history, studying cardiac death, looking at, we run baseline EKGs before ever starting Celexa. Maybe that's a little hypervigilant, but we feel that it's necessary because then there's no guesswork. When it comes to non-compliance, what would be a good option for a patient who occasionally, an SSRI that would be good for a patient who tends to not be as good at taking their medications? Prozac, yeah, absolutely. So it comes in a once weekly. The dosing on that's kind of weak, like it's 90 for the weekly dose, but it's a good option, right? So you've got fluoxetine. Indications for that are depression, anxiety, PMDD, etc. But it does have an extremely long half-life, so that can be a very good option for people who are not always as conscious of taking their medication.
What's the name of the syndrome where there is genetic QTC prolongation? It starts with a B, B as in boy.
Yeah.
Brugada syndrome, exactly. What is a normal QTC interval in average adult?
For men is less than 450 and women is 400 to 430.
460, very good. 460. At what QTC prolongation do you get to a sad stipple?
Above 500.
500 milligrams, yep. Exactly. What's the maximum dose of citalopram or Celexa you can give in geriatric patients over the age of 65? 20
Many of
milligrams.
them. I was gonna
So-
go half the max, so yeah.
Yeah, have to.
Paxil, let's talk about that one. Paxil is very effective, does things you need to know about that. Discontinuation syndrome can be brutal. So recent studies have found that Prozac can be used to taper patients off of Paxil because it's long acting and can help with that discontinuation. A lot of people, once they're on Paxil, really can't get off of it. Weight gain is a big problem with it. Pregnancy, does anybody know what it can cause in pregnancy or what the risk is to childbearing women? I remember this for my boards, PPP, so pregnant women, pulmonary hypertension, Paxil. So that's something that's important to know when you're looking at prescribing it to women that are potentially at a risk of getting pregnant.
What is the safest SSRI in patients with cardiac problems? Choices are fluoxetine, also known as Prozac, sertraline, also known as Zoloft, citalopram, also known as Celexa, paroxetine, also known as Paxil, out of the four. Choose one antidepressant which is the safest antidepressant in patients who have cardiac problems, any kind of cardiac problem. Sertraline.
Good job, yes,
Zoloft.
it's almost always gonna be so. So with the exception of liver dysfunction, we work consultation liaison psychiatry, so seeing patients, and you really think about things differently because it's a lot of what can I prescribe this patient? They've got kidney failure, they've got XYZ. I mean, Zoloft seemed to be the one that would always turn out to be one of the safest options.
Yeah, so in real life, when you're practicing, you got to know all your medications on the tips of your fingers. Because you're not gonna go and Google everything and try to figure out on the run. So you got to have a pretty good concept. If you see a patient initially and you decide that the patient is an appropriate candidate for an antidepressant, SSRIs are not necessarily always the first choice. If a patient is extremely anxious, then I would usually prescribe what? Vibrate. Vibrate has got 5-HT1A partial agonist activity, which is like buspirone. So Vibrate can be effective. If a patient has cognitive impairment, difficulty staying awake during the day, what antidepressant, not SSRI, would I prescribe?
That's the next slide, but
Vortioxetine, also known as Trintellix. Out of SSRIs in pregnant women, what are some of the safe treatment options from SSRI standpoint?
again, it goes back to Zoloft, so that's typically when
Zoloft.
yeah, I mean, and
Prozac, Celexa.
right. So, and lastly, just on this, before we move on to the next, serotonin syndrome, it's real. If you've seen it, it happens. Do you guys know what to watch for in serotonin syndrome?
Flu-like symptoms.
Yes, yeah. And, what would be your big differentiation?
Let's do a clinical vignette.
I have one on NMS.
Yeah, let's do one on serotonin
Okay, you
syndrome.
got it.
So there's a 36-year-old Caucasian male who is on tramadol and is also on Prozac. You prescribe trazodone, and then 3 days later the patient develops a fever of 103 degree Fahrenheit. Blood pressure is 160 by 95. Heart rate is 110. Patient is profusely sweating, is myoclonic jerks all over, and is confused. What would you do? Increase the dose of Prozac. Number 2, discontinue Prozac, but leave the patient on trazodone. After all, what could go wrong? Number 3, discontinue all medications. Number 4, discontinue Prozac, trazodone, but not tramadol. Just make a guess.
The last one.
The last one.
No, you'll discontinue everything.
And what would be your antidote?
Forgot.
Calcium.
Ciprofloxacin.
Yeah,
Good job.
tramadol along with Prozac can cause serotonin syndrome. And you're throwing in like tramadol, which is serotonergic, Prozac, and trazodone.
Okay, and we can go to SNRIs and NRIs now. So your SNRIs or NRIs, so serotonin norepinephrine reuptake inhibitors, or an NRIs, which are just without the serotonin norepinephrine reuptake inhibitors. Hypertension is a big problem with these. I don't know how many patients that we see that have just been stuck on Cymbalta or Effexor, and nobody is monitoring the fact that their blood pressure just keeps climbing and they're 27 years old. Now, does this person who's normal weight, who, came to us with baseline blood pressure, 105/60, who's now 140/80 after 2 months of being on a med, have primary hypertension? No, we've caused that. So it depends on how stable, if the patient is doing fantastic and it's gonna cause a serious harm to take them off, then I might consider treating the secondary hypertension. I don't like to have to practice tertiary medicine, but it really depends on your patient. If they've been suicidal and Effexor is what has worked, I might end up having to leave them on that medicine and then, treat the blood pressure. But if this was a first line medicine, they're pretty stable and they're like, yeah, I'm fine to try Prozac, then I might do a switch. But blood pressure, I would say it's very few and far between that I do not see a patient that has some sort of blood pressure spike with starting an NRI. Why would they have a blood pressure increase?
Noradrenaline sugar.
Right, so I mean, it's inevitable. Additionally, there's a slight risk of activated mania. So here's another, let's say you have a patient you're treating, a 16-year-old female who comes in with anorexia symptoms. She's restricting food. She is monitoring her weight constantly. Patient has childhood history of epilepsy that has since resolved. What medication are you gonna avoid like the plague and prescribing for this young lady? Absolutely, Wellbutrin. Lowers the seizure threshold. Anorexia is a contraindication. Interestingly, Wellbutrin is used to treat binge eating disorder. However, it's contraindicated in anorexia and bulimia. Go figure. Wellbutrin can also be used in various other dependent style behaviors such as smoking cessation. And then off-label, we use it for methamphetamine dependence in some cases. Most of the, so SNRIs like Effexor, Prestige are gonna have a discontinuation syndrome. You do not wanna abruptly stop them or your patient's not gonna be very happy. So unless there's a emergent reason, we tend to taper patients off. Effexor is probably the most brutal to get off of, so we tend to taper it down slowly and gradually. They have a broad level of indication, so like Strattera, Qelbree, those are FDA approved for ADHD. Wellbutrin occasionally off-label. Also, they have efficacy in treating chronic pain, fibromyalgia. And recently I've started seeing them used for headaches by neurology. And yeah, so anything else to add?
Oh, I just have to add that Wellbutrin contraindications are, as she said, seizures, anorexia or bulimia, and also head trauma, history of head trauma. That's important to know. So if somebody had a mild concussion, I wouldn't worry too much about it, but if lost consciousness, then I would probably avoid Wellbutrin, traumatic brain injury. And then clinically, how do you taper somebody off of a SNRI? You do it gradually over a period of couple of weeks. So don't abruptly stop. Okay, go ahead.
Okay, we can move to tricyclics.
One more thing, SNRIs are really effective for neuropathic pain. So they are FDA approved for like diabetic neuropathy, like Cymbalta is. So you often use it for with gabapentin. Maximum dose of Cymbalta is 120 milligrams a day, 60 BID. Effexor XR, what's the maximum dose in adult outpatient? What's the maximum dose in inpatients?
225.
And 375. And I think that's good.
Well, one other thing, Cymbalta strangely has an FDA indication in children. So kind of unique there when we're going.
Prestige is an active metabolite of Effexor. It's like venlafaxine metabolized into O-desmethyl venlafaxine.
Less discontinuation syndrome, but according to Stephen Stahl, who's kind of our godfather of psychopharmacology, says that any dose over 100 is not, you're already saturated, so there really isn't a point in titrating.
What are some of the symptoms of discontinuation syndrome? It's like dizziness, lightheadedness, electric shock-like sensation. Back in 1997, when I was in my residency program and Effexor had just been FDA approved, It just came on the market. There was a patient I put on Effexa and the patient missed some doses. And he called me up saying that every time I move my head, it's like somebody is slapping me.
Head zaps, they'll call it
Yeah.
too, yeah.
So
brain
those are
zaps.
the discontinuation syndrome. They're not life-threatening, but they can be unpleasant and discomforting.
Okay, so we'll move to MAOIs and tricyclics. So MAOIs, most people don't use them. I use them. Not as much as I used to, but they definitely have a clinical purpose. They used to be used widely. Why do we not use them? Well, they're extremely inconvenient medications. They do not play nice with others. They interfere with everything under the sun. And it's very unusual in psychiatry and our line of work to get a patient who is not already on various psychotropics that make it extremely difficult. So let's say I have a MAOI appropriate candidate who is severely depressed. I now have to say, well, guess what? We're gonna go without an antidepressant for 2 weeks, if it's say Celexa, 4 weeks if it's Prozac, and you're not gonna be on anything while we wait to load you on an MAOI. Now, that's not a good situation to be in. Hence why we don't use them as often. But if you do, occasionally I get a patient who comes in with something like severe social anxiety, agoraphobia, who I think, this is an ideal patient, they're not on any medications, we could do an MAOI and they're okay with the dietary restrictions, then that might be a good candidate to start. So the ones that you guys have listed here, there's Nardil, Parne, MSAM. MSAM is a patch. That one came with less dietary restrictions on the lower dosing of the medication. It's prohibitively expensive and insurance is always going to require that they have already failed Nardil and Parne before they'll pay for it. So it didn't get a lot of usage, but it was good in theory. Hypertensive crisis is a big deal with MAOIs. It's a possibility. Tyramine, what is it? Can you guys give me some examples of what education you give to a patient who does need to monitor that?
Can't eat cheese or wine.
Smoke food. Aged cheese, yeah. And fermented beer, sauerkraut. Sometimes I give the patient a little sheet and they're like, who eats this stuff? And they're like, I'm fine with it. But when they see dark chocolate, then they're a little less happy.
Back in 1980s, there was a woman named Libby Zion in New York City who goes to an emergency department. She was on a MAOI. The resident was overworked, who had been working 70, 80 hours that time, and prescribed her Demerol, and she eventually died of serotonin syndrome. So as a consequence, they limited residency hours, the number of hours you can be on call, and they instituted mandatory breaks. What is an IV antibiotic typically prescribed in inpatient settings by infectious diseases that can cause serotonin syndrome with MAOIs or SSRIs? Which one? Linezolid, excellent, very good. Also known as Zyvox.
Tricyclics. So somebody said them earlier for cardiac and QTC. That was correct. Tricyclics are still pretty widely used, not so much by us, but by neurology. They seem to really like tricyclics, even in my pediatric patients, and a lot of them on nortriptyline, amitriptyline for headaches, cyclic vomiting, various things that do make it a little hard to treat depression because they interfere with things. And then if they're not asking things like, does this child have a history of overdose? And then they're giving them tricyclics, those can be absolutely fatal in an overdose. You never want to prescribe a tricyclic to a patient who's an alcoholic. Why? Well, I mean, it's obvious that tricyclics and alcohol use is a lethal combination, and somebody is likely to be successful in either an accidental overdose or suicide or attempted or suicide. In addition, anticholinergic side effects can be pretty pronounced. We see a lot of tachycardia with them, but they can be very effective in treating pain. Sleep disorders, we still use doxepin, headaches, depression, anxiety, we have dry mouth constipation. There's one tricyclic that can be activating that's been studied in ADHD. It's old. Does anybody know which one that is?
It can cause sudden death in kids. It starts with a D.
Oh, no, I was talking
Oh,
about
you're talking about something. Which one?
protriptyline. I
Oh,
said
oh,
Ave,
bivactal.
bivactal.
Well,
Yeah.
desipramine can cause sudden death, and we don't use it for ADHD, and it's activating too.
Yeah.
Besides tricyclic, Effexor or venlafaxine can cause serious consequences with drug overdose. So be careful prescribing the quantity. And then duloxetine or Cymbalta, if somebody is actively drinking alcohol, they can have liver damage or hepatotoxicity.
Anything else on tricycle?
So I think let's move
Oh,
on.
blood levels. If you're on nortriptyline, you're going to be getting therapeutic blood levels.
Amitriptyline is metabolized into nortriptyline, so amitriptyline plus nortriptyline level. Imipramine is metabolized into desipramine. So ID, that's how I remember. Imipramine plus desipramine level and amitriptyline plus nortriptyline level, and you do baseline EKG. Somebody's got second degree heart block or third degree heart block, never prescribe tricyclics. Tachycardia, do not prescribe tricyclics. That can cause anticholinergic side effects, can cause tachycardia.
Okay, and we'll briefly hit the other antidepressants or the next slide. So firstly, when we think of other antidepressants, that means they are not in those categories. One back. Remeron. So Remeron we use actually quite a bit. So weight gain is a known and expected side effect, so it might be good for a cachectic patient or cachectic, however you want to pronounce it, that is struggling to gain weight. Is a treatment for nausea, so we do use it a lot, like in patients who maybe have cancer, also nausea. It's a good treatment option. It also helps with insomnia. Interesting fact about Remeron. Patient comes in and they're taking 15 and they're saying, well, I'm super drowsy. You don't want to tell them to take half. Why? Remeron has a paradoxical effect. It is more activating at higher doses, more sedating at lower doses. So that's something that I educate my patients on. When combined with an SNRI, such as Effexor, Pristiq, or even Wellbutrin, that's the colloquial term, California rocket fuel. You'll get a little thing that pops up saying drug-drug interaction. It's actually a desired one in some cases when we're really working to boost a patient out of depression quickly, especially in inpatient setting. Combining an SNRI with, what is the appropriate term for Remeron or in the class? It's a
NASSA, noradrenergic selective serotonergic antidepressant.
It has a synergistic effect with the.
In low doses, it's antihistamine. In high doses, norepinephrine kicks in. That's why paradoxical activation at high doses. Max dose is 45 milligrams. Sometimes you can go to 60. If you're crazy, you can go to 75 or 90.
Trintellix, we talked about that already. It's a newer one. It does have cognitive properties, has been well studied in geriatric population. They made a point to do that. Trazodone, more of a sleep aid, but as he was saying earlier, can still cause serotonin syndrome. If we were to use it for depression, you would need doses that were really high for it to be remotely effective.
What can happen with trazodone, which can cause impotence or death?
Priapism.
Yeah, what's the incidence? 1 out of, I'll give you 4 choices. 1 out of 100, 1 out of 1,000, 1 out of 10,000, 1 out of 100,000.
The B.
B, that's right. 1 out of 10,000.
Okay.
Right.
So next we have Spravato, which is esketamine. That's a whole other topic of conversation. It's FDA approved for suicidality right now, treatment-resistant depression. It does require a REMS program. It's done under monitor. We do Spravato at our clinic. We do not do IV ketamine. It's not something that we use, but we do use Spravato, and I've seen pretty good results in treatment-resistant depression.
How do you define treatment-resistant depression? How many antidepressant failures? I'll give you choices. 1, 2, 3, or 4.
3?
2.
Great.
That's any resistant in psychiatry. 2 failures, antidepressant resistant, 2 failures, antipsychotic resistant. Go to closer.
Yeah, so next we have one that I was really excited about when it came out. Sulfamezo, has anybody heard of that? So it's the first FDA ever approved drug for postpartum depression. It is curative. It was an IV infusion, very difficult to use. So when you have an IV infusion that required, I believe it's 56 hours by a registered nurse to administer because it can cause sudden syncope. That's not super practical, but it was, brilliant. It worked on GABA A. Recently, they finally got the oral form, which is Zureve, 14-day medication stop, and the patient returns to baseline. This is groundbreaking. We're really hoping that the new category GABA A is going to revolutionize the industry, because if we can get patients on a medicine that brings down symptoms within 2 weeks, like we would an antibiotic, that would be pretty cool. But right now, the area of study and the funding was on postpartum. But they did finally get the oral form very, very recently, so eager to see where that goes. Okay, we can move on to the next one. This is our first generation antipsychotics. Yes, we still use them. So this is, your Haldol, Prolixin, and we see a lot of these in our residential care sites, people who've been on them extremely long term, and this is what works for that patient. They're not, we have better options, but for some people, they are the option. So when we've got severe schizophrenia, agitation, etc., they're what we end up going to. So they're going to block dopamine to a whole different level than what your SGAs do. Dystonia, you can see, especially like in pediatrics, I've seen with Thorazine, where we have lockjaw, and then there's full-on tardive dyskinesia that you'll see more so with Haldol. So who is at your highest risk of tardive dyskinesia?
Okay, yeah, I'll give you some choices. Okay,
Elderly, right?
Elder, yeah, like
yeah,
over
okay, but
60.
let's not mess with choices. So geriatric females who are diabetic, African American.
Yeah.
That's the highest risk. African American females, geriatric diabetic.
So they can also have some anticholinergic side effects, and I've also seen catatonia induced by first generation antipsychotics. So I could do an entire other presentation on catatonia. That's something interesting I've studied quite a bit, but it can happen with first generations, and when you see it, it's something you don't forget, and sometimes gets overlooked, or just that the patient is in, a negative state of schizophrenia. But when they're having things like this, no, that's not, that's catatonia. So here's a vignette. You are on call, physician for an inpatient unit, you're taking call. You get a call from the charge nurse who tells you a recently admitted 24-year-old athletic African-American male who was admitted for agitation, who's been on scheduled Haldol and Risperdal, is due for their next dose. However, patient is extremely agitated, rigid as a board, and has 104 fever. Well, it's right there, so it's not too much of a vignette, but what is going on here and what is your treatment plan?
Yes.
What is it?
EPS.
Not EPS.
NMS.
NMS.
NMS,
It's on the
yes.
screen.
EPS is a broad category extrapyramidal side effects, which includes dystonia, akathisia, tardive dyskinesia. Neuroleptic malignant syndrome is an idiosyncratic reaction similar to malignant hyperthermia. On one spectrum, we got serotonin syndrome, on another spectrum, we got neuroleptic malignant syndrome. What can cause neuroleptic malignant syndrome? Antipsychotics. What can cause serotonin syndrome? Antidepressants. What else can cause neuroleptic malignant syndrome? Well, medications that reduce dopamine. So even, medications given Reglan or metoclopramide, which is given for GI problems, or estelazine for intractable hiccups, compazine, also known as prochlorperazine, which is given for like your nausea and vomiting, they can all cause neuroleptic malignant syndrome, especially in combination with antipsychotics. Serotonin syndrome, not only antidepressants, but medications like tramadol or anything that increases serotonin can cause. Degree of fever is much higher in neuroleptic malignant syndrome, like malignant hyperthermia kind of a picture, like 104, 105, 106. Fever is less severe in serotonin syndrome.
And yeah,
Confusion is common in both. Autonomic instability common in both, but much more prominent in neuroleptic malignant syndrome. Muscle rigidity is pathognomonic of neuroleptic malignant syndrome. On the other hand, myoclonic jerks is in serotonin syndrome. Discontinuation of offending agents, all offending agents, is the treatment of choice for both conditions. Immediate transfer to ICU. This is definitely going to be a board question for you guys. The first thing to do, as soon as you suspect neuroleptic malignant syndrome, is stop all antipsychotics, any medication in addition that could be depleting dopamine. Number two, immediately transfer the patient to ICU for supportive measures like cooling blanket and all. Number three, immediately check a serum CK. Serum CK is going to be extremely elevated.
and a CBC.
Then call neurology consultation, and then you treat with direct muscle relaxant like dantrolene, and then you also use bromocriptine, which is dopaminergic.
And you need to, so you can see rhabdomyolysis and you can see NMS. Typically, I mean, if I see one or the other, I'm gonna treat it as such. We've seen patients who are just being told they were agitated or such, and then gone in and said, no, that patient is in NMS. So it's serious, you have to look at. And there's particular patients who are at a higher risk of rhabdo as well. So athletic males, younger males are higher risk of dystonia, higher risk of rhabdomyolysis.
I mean, over the years, I've probably seen 20, 30 cases of NMS. I've probably seen 40, 50 cases of serotonin syndrome. Ciprofloxacin, we already talked about for treatment of serotonin syndrome.
We'll move to SGAs. So that's atypicals or antipsychotics, and then some of which are new. These medications are really different. So one SGA is not nearly the same as the other. Some are more act as antidepressants, some are more, have more anxiolytic properties, some have more antipsychotic properties. So you really, when you delve into this class, need to know what you're doing and what you're prescribing. The biggest thing, from a primary care standpoint of what somebody needs to be monitoring if a patient is on a second generation antipsychotic is their metabolic side effects. And not all of them, I mean, some of them to a lesser degree, like Geodon isn't typically going to cause it. It could. Vraylar, it just kind of depends. But some of your biggest offenders for metabolic changes are Zyprexa, Seroquel.
A single dose of olanzapine or Zyprexa can cause, number one, I'll give you 4 choices. Tell me the right answer. Number one, diabetic ketoacidosis. A single dose of olanzapine, also known as Zyprexa, can cause, number one, diabetic ketoacidosis. Number 2, insulin resistance. Number 3, profound hypoglycemia. Number 4, QTC prolongation. What is the correct answer?
QT.
Nope.
Insulin resistance.
Insulin resistance, exactly.
And so the Zyprexa can be extremely effective. It has antidepressant properties. It's a fast-acting antipsychotic. But I mean, weight gain and diabetes is just, it's the prevalence is very, very high. Not as high quite so much though as our friend clozapine. I think clozapine has even a higher incidence.
Yeah.
But we'll get to that one in a second. Your biggest akathisia agents, do you guys know what akathisia is? So that's a form of EPS where you feel like you're constantly moving.
Okay, so this is akathisia. Like I'm not able to sit still. I'm constantly moving. Patients are like
In
moving all
your
the time.
office.
If they are sitting there, akathisia patients, they are constantly like this. Okay. What do? You think the patient is more psychotic, you give them more antipsychotic, what will happen? It will get worse.
They'll
and
kill themselves.
Eventually, some of them will kill themselves.
Yeah, so it can get to the point where the akathisia is so bad that the patient just wants it to stop and they will actually commit suicide because the agent is just causing them such severe discomfort and agitation. Your biggest offenders are aripiprazole, Abilify, and causing akathisia. Vraylar in higher doses, and then Rexulti to a lesser degree.
Vraylar is the highest, cariprazine is the highest.
Is it?
Oh, yeah. I mean, cariprazine is the highest.
So now we use these medications still, it's just gonna be monitoring, and then a lot of the akathisia is dose dependent, but not always.
What is the treatment for akathisia besides stopping the offending agent?
Beta block?
Beta blocker, excellent. And what else? Benzodiazepines along with beta blockers.
Yeah.
What is this called? If I can't open my jaw,
Alright.
it's super tight. What is it called?
Yeah.
Okay, all right. And what is this called? Like I'm blinking my eyes and moving my tongue. What is this called? Tardive dyskinesia. Okay.
And if somebody's eyes roll back in their head,
It's called oculogyric crisis. The
we've seen
treatment
that
is
from
cogentive.
hospital.
Okay, what is this? I'm jerking I've seen patients who do this. A female comes to you and the female is like jerking like this.
Hemiballismus.
Exactly. What neurologic condition can cause hemiballismus? Start with the H.
Huntington.
Huntington's
Yeah.
disease. Very good.
So if we were just hitting our atypicals, I know we're close to time, they do come in long-acting injectables. There's some newer ones on the market, like Cobenfy, it's first in its class. So that one is not working on dopamine the way that our other agents are. Do you wanna tell just a few seconds about Cobenfy and why it's a game changer?
Yeah, it's the latest novel treatment. It's a M1, M4 agonist. M1 is top down from cortex to the brain, and M4 is bottoms up from striatum to limbic system. So it's a combination of xanomeline and trospium. Xanomeline is a cholinomimetic agent. It's a orthosteric agonist for M1, M4, and trospium is a peripheral anticholinergic. The starting dose is 50/20 milligram 1 PO BID for 2 days, then you go up to 100/20. The maximum dose is 125/30 BID. And
Brand new, like 4 weeks old.
anybody with liver problems, you do not prescribe it. You give it 1 hour before food or 2 hours after food. Contrary to some other antipsychotics that you should give with food,
Like Geodon.
Geodon and Latuda.
And Geodon can cause what?
You were right, you know, that kid, you were absolutely right about QTC prolongation, but it was not Zyprexa, it was Geodon, ziprasidone.
That's what we watch for. Geodon is metabolically neutral for the most part and works more as an antidepressant than an antipsychotic, but it can also be used for acute situations in IM form. Latuda is an agent I tend to use in pregnant women if they are psychotic. Back when we had categories, it was a category B. And so now, you know, so animal studies also did not find upset. I have personally had multiple patients with schizoaffective schizophrenia during pregnancy I've had on Latuda who have not had any adverse outcomes during pregnancy. Doesn't mean they won't, but just in clinical practice, I've been able to use that with good success. And it also has some lower pediatric indication. Safety profile is a little bit better, softer than some of your other agents. Patient has strong family history of breast cancer. What agent you might want to avoid when it comes to atypicals? There's 2 actually. Paliperidone
R.
and iloperidone, Risperdal and Invega. Why? They elevate
Estrogen.
prolactin. So we get a baseline prolactin on all of those patients. There was a lawsuit several years ago about Risperdal causing breast enlargement in young males. So something we watch for, gynecomastia. But in general, we run a prolactin just to make sure, because it can also cause pituitary adenoma.
So everything we are talking to you guys about, we have seen it firsthand. So there's nothing
True
that is
story.
theoretical here, 100% clinical. So, we've seen cases. So we have had patients who suddenly start complaining of headache. And then, who's on high dose of Risperdal. You check a prolactin level, it's really high. You do a MRI scan of the brain with emphasis on pituitary, turns out patient has pituitary macroadenoma or microadenoma, depending on the size.
We'll briefly just switch clozapine and then we'll move to mood stabilizers so we can get to those. Clozapine is our gold standard. That is 2 or more failures on antipsychotics. And in reality, it tends to be more like 4 or 5 before we go to it. Why? It's inconvenient, but it is highly, highly effective. Why is it inconvenient? Patients have to get weekly CBCs for a very long time. We're watching for agranulocytosis. We get baseline EKG, we get a annual clozapine or clozapine level, as well as, if you want to be very judicious or cautious, a troponins and
Troponin,
yeah. And so it has suicide protective properties. It can actually help prevent suicide. It can be a treatment for tardive dyskinesia, interestingly enough. So this is a great option for patient residential care where the blood draws are easy to get to. Diabetes can be a major problem with this medication, and sialorrhea, which is excessive salivation. So that can be things to watch for. We don't have time to talk about smoking, but that could have a profound impact on your dosing of both Zyprexa and clozapine, so something to look up. But
Smoking reduces the blood level of both.
But we don't avoid it simply because it's inconvenient, because for some patients, this is the thing that will save their life and give them a quality of life. I've had a patient, long-term residential care, who was in and out of the hospital all the time, was put on clozapine and was able to go back to living with their family and doing some ADLs with pretty severe schizophrenia, and why, had success. Nobody else was willing to do clozapine with this patient. We did, and it's worked well. So it can be life-giving for some people. Okay, next one.
A couple of things you need to know about clozapine is, number one, CBC, as she said, for first 6 months weekly, then every 2 weeks, then for another 6 months, then once a month. Then bone marrow suppression, agranulocytosis, the incidence is about less than 1% of cases.
We've seen it.
So,
but-
yeah, and it can cause potentially fatal adverse outcomes like aspiration pneumonia because of sialorrhea. It can also cause cardiomyopathy. So just be aware of that.
Okay.
And then the new medicine Cobenfy, that supposedly does not cause tardive dyskinesia and supposedly does not have metabolic adverse effects.
Mood stabilizers. So we use them, neurology uses them. We've got Lamictal, Trileptal, Tegretol. They're used for bipolar. We use Lamictal, some in borderline personality, adjunct depression, Tegretol, Trileptal more so in anger, disability, intermittent explosive disorder. And they definitely have their place. In general, they're well tolerated. We don't have metabolic side effects. We can have CMP changes, so that's something to watch for. Tegretol, you do have to get blood levels with, and it reduces the efficacy of everything under the sun.
So you don't like your patient, you want to kill your patient. What two anti-epileptics can you prescribe together that can kill your patient? Starts with a D, the other one starts with a L. Tepacoat with Lamictal.
Now people do it.
If you put them on high doses, the chances patient could die. What would be the potential cause of death? It's a skin rash. What
It's
is
up
it
there.
called? Stevens-Johnson syndrome.
So we do this a little bit different than neurology. They titrate faster than we do for when we're seeing mood disorders with lamotrigine, we're typically gonna do 25 milligrams for 2 weeks and then go up to 50 milligrams. 10 on patients will develop a benign skin rash. We don't try to differentiate between the skin rash. They develop a rash, we stop the medication, tell them to take Benadryl, and we move to something else. So also we can see hyponatremia with which of those? Of those three? Well,
So I had a patient who was an ophthalmologist, was running a very big surgery center, real life incidents, and was put on trilaptol, developed severe confusion, ended up having profound hyponatremia. So just be aware of that.
moving to Depakote. Depakote can be a very good option as far as mood stabilizer. It's used a lot in inpatient setting. We still use it. Ammonia, hyperammonemia. It's a real thing. It happens. We would be very surprised how many people put patients on Depakote and they get valproic acid levels, but they fail to get an ammonia. We've seen pretty significant hyperammonemia and have had to even put children on lactulose for highly elevated ammonia. You guys probably already know about hyperammonemia, but that can be very serious.
What causes hyperammonemia? What biochemical deficiency?
Like a liver failure.
L-carnitine deficiency. L-carnitine. Okay, then Depakote is the single most teratogenic agent.
I've got that on there too. Neural tube defects. So ironically, it is the safest for breastfeeding. So you have a patient that cannot take Depakote during pregnancy, but patient wants to breastfeed and they have mood disorder. As long as they're not at a very high risk of getting pregnant again, then Depakote is the best option. But when we're looking at childbearing, as far as, getting pregnant, it is not a good option. So if we have a patient that's at a potential risk, we tend to put them on folic acid. But in general, we're gonna avoid it and use something else.
What dose of folic acid should you put somebody who's on Depakote versus what dose of folic acid in somebody who's on Lamictal? 1200 microgram for Lamictal, 4 milligrams a day for Depakote, as well as carbamazepine and trilaptol.
So lastly, in this category, we have lithium. Lithium is very important. It's still used. It's still our gold standard for mania. They really haven't found anything better. I don't know that they will. Lithium has one of only two things that can actually help prevent suicidality and drastically improve your patient's prognosis if they're suicidal or violent, and that's lithium and clozapine. Those are the two medications that actually have neurodegenerative properties. So this is still gold standard. We do therapeutic drug levels 0.6 to 1.2 is where you want your lithium level to be. What do we monitor for? Lithium toxicity. Patient appears intoxicated, slurred speech. Tremors are not always a side effect of lithium, but they are toxicity, but they can be. A lot of patients will have tremors regardless, and we have to treat them. We're gonna be monitoring their CMP, their renal function. It can cause kidney damage, kidney failure, thyroid dysfunction, and diabetes insipidus. If you did rotations with us, we also told you that lithium is a treatment for a different endocrine condition. Does anybody remember what that is?
It's a nephrogenic diabetes insipidus, or is it just
That causes diabetes.
a cause?
Would it be-
Yeah.
Would it be on the other end, like SIADH?
Yeah, there you go.
There you go. Very good.
No, you're right, NDI is a side effect, and you're right, SIADH is what you can treat with lithium. So
Good. Okay, next one.
one thing about lithium level, try not to exceed 0.8 milliequivalents. The target dose in clinical practice is 0.6 to 0.8 milliequivalents per liter. If you are going to 1.2, you're bordering on toxicity. Like 1.4 and higher is toxicity.
So anxiolytics, I won't talk a whole lot about those. We have our benzodiazepine, non-benzodiazepines. We have propranolol. Propranolol is a beta blocker that helps with situational anxiety. Obviously, don't prescribe the patient with asthma. And we can use it for like test anxiety, public speaking anxiety we know is coming. Gabapentin is only going to work in really high doses to treat anxiety, is what we've been taught or shown. Hydroxyzine is anticholinergic. It is on Beer's criteria. I've had people think that it's safer to put a patient who's, 72 on 50 of hydroxyzine TID than to give them a low potency benzo. Not true. That's actually the opposite. Benzodiazepines in that class of patients is probably safer than using those anticholinergics medications like hydroxyzine. Benzodiazepines can be addictive and habit forming, so we use them sparingly, but they do have a place. They're the gold standard treatment for catatonia. They can be used for alcohol as well as other forms of withdrawal. And for acute panic attacks or various other things like MRIs or phobias, they're still widely used, panic disorder, and they act quickly. But in some cases they're underutilized, they can be overutilized.
Let me give you a quick quiz. What is the most potent benzodiazepine out of these four? Klonopin, also known as clonazepam, lorazepam, also known as Ativan, diazepam, also known as Valium, or alprazolam, also known as Xanax. Klonopin is the correct answer. 0.25 milligrams of Klonopin is equal to 1 milligram of lorazepam is equal to 0.5 milligrams of alprazolam is equal to 5 milligrams of diazepam. That's how you remember it.
And your safest benzodiazepines from a liver standpoint, remember this acronym LOT, LOT, that's lorazepam, oxazepam, temazepam. So if you have a patient, alcohol, highly elevated liver enzymes, lorazepam, oxazepam, temazepam, those are your safest options. Okay, so moving on to sedative hypnotics. We'll just briefly touch those. We still use benzodiazepines, but sparingly, such as Halcyon, Restoril. I mean, usually it's just a patient who's been on them forever, can't get off of them, and that's where they are. Zolpidem, it works, but it can cause crazy things, sleep driving, sleep eating, racist tweets in the middle of the night, like that you guys might have seen.
It's more of an exaggeration. I've
It
not
is,
seen too many
yeah.
cases. I've probably seen maybe 1 or 2 cases.
Sleep eating, I hear more frequently from my patients that they've had, but that doesn't mean they'll necessarily stop it, but they might get up in the middle of the night and have a snack, and it's newer agents have lower abuse potential, like Belsomra, Dayvigo, less morning hangover effect. These are good options if you can get insurance to cover them. They do work really well. We try to emphasize sleep hygiene and make sure that we're not actually causing the insomnia with other psychotropics before just going and throwing something on the sleep. Melatonin is fine. It can cause very vivid dreams. And then we use prazosin off-label for nightmares associated with
Talk to them
PTSD.
real fast about obstructive sleep apnea and narcolepsy.
I have a slide on that next.
Okay.
Okay, so that moves us to why might they have this? Modafinil, so obstructive sleep apnea or conditions like sleep shift wake disorder, narcolepsy. Those are, we use wakefulness promoting agents for those. You have a patient who has a BMI of 36. They are snoring, they have hypertension, and they have a lot of daytime fatigue and some depression comorbid. Am I just automatically going to diagnose them with major depression? No, I'm going to order a sleep study and look at if the patient potentially has obstructive sleep apnea. Why? Because it can cause all of those things. It can even mimic ADHD. So in those cases, these patients have a very high incidence of automobile accidents. And so we really want to make sure that we're effectively treating and screening for obstructive sleep apnea. It's highly prevalent. And these are the agents, daytime agents that we use to help promote wakefulness, which are Nuvigil, Sunosi, and Modafinil.
What cardiovascular condition can undiagnosed and untreated obstructive sleep apnea cause over a long period of time?
AFib.
Cardiovascular condition. called pulmonary hypertension. What is cataplexy when it comes to narcolepsy? Cataplexy, anybody knows what's cataplexy?
Dropping off.
Dropping down, okay. What are hypnagogic hallucinations? What are hypnopompic hallucinations? Hypnagogic hallucinations when you're falling asleep, hypnopompic, you wake up with great pomp. If you are like the French emperor. So it's like, hypnopompic. But they are not true hallucinations. They are part of narcolepsy. They are not true
We had
hallucinations.
one of those a couple
And
weeks
sleep
ago.
paralysis.
So next, and this is our last slide, we didn't get to addiction drugs, that's a whole different category, so we can do that potentially another time, but, oh, no, sorry, I had a couple on the stimulants, but, just basically stimulants, they are still first line for ADHD. The non-stimulant medications are not near as effective, but we might use them in a patient who has things such as tics, somebody who has cardiovascular risk, abuse potential. So we do periodic drug screens. Know that your rapid drug screens cannot screen for methylphenidate. They can only screen for amphetamines. So ritalinic acid is a send out drug test. But I tend to favor using methylphenidate products with my patients. They cause less anxiety, they're softer, they're better tolerated, less cardiovascular risk. I really don't like using Adderall. One, you have a phenomenon called tachyphylaxis, which tachyphylaxis, does anybody know what that means? It's when a medication that you're using is, particularly a stimulant, is no longer as effective as it once was. So it's a phenomenon where that same dose of medication is, wears off and it has, it's no longer effective. So we see that a lot more with the amphetamine products, higher abuse potential. And whereas the ritalinic acid drugs such as Focalin can also have antidepressant effects because they have a downward effect on norepinephrine. But stimulants are good class medication. We just get EKGs, make sure your diagnosis is accurate because we don't want to activate mania. But we do have patients who have comorbid bipolar and ADHD, and they still have to have their ADHD treated. So recent study.
Each year of stimulant use increases risk of cardiovascular side effects by 4%. Sudden cardiac death can happen. It's rare, but can happen.
Monitor high blood pressure, and then growth delay. What they have found is that there's not so much growth retardation as growth delay. So patients, when we're doing growth charts, we're seeing that they tend to still hit their growth milestones. It's just that they might come slightly later than they would in, somebody who's not been on stimulants. That's what our longitudinal study.
Okay, a final word about psychiatry. Psychiatry is a very, very challenging, very interesting specialty. Those of you who don't like touching patients, like I didn't like touching patients, I didn't like blood. I went into psychiatry and I've been extremely happy. I've been practicing for 26 years.
Okay.
And I'm happy.
Are there any questions about, I know we covered a lot of material in a short amount of time. We basically wanted to give you guys the really broad overview of these different classes and the pearls that you need, whatever discipline and what to watch for, and hopefully gave you some ways to remember these.
Someday we'll come and do a lecture on business of psychiatry, because the business of medicine is like various specialties, each is different, but I can talk about business of psychiatry.
Do you guys have any questions about psychotropics? We didn't get to Alzheimer's, dementia. I think that's more neurology, and then substance use is a whole different category and something that we could delve into at another time, but it requires kind of its own presentation. You guys can keep this list as what we give to our patients, but it does kind of break down the different medications. So, but any questions at all? Yes, sir.
I have a question about propranolol and asthma. If they can't take it for asthma, do you prescribe a benzo or what?
You can use a more selective beta blocker, like you can use atenolol instead of propranolol.
But if they're benzo appropriate, then I don't have a problem giving them a benzo, like.
Yeah, I mean, that's fine, but I'm not shy about this.
Yeah, I mean, we're judicious, but it depends, like propranolol, you have to remember, is not first line, it's still an off-label option. Any other questions? Okay, well, thank you guys for having us, and
just any questions come through on Zoom.
Okay. Awesome, thank you for having us.